I totally agree. I'm going to actually come back to some points with Riyadh, but before I go there, one important point, and this is a teaching point, if anything, Farshid, I'm asking you because simply you are the one who presented the data. Remind me, lenvatinib, when they evaluated it part of the REFLECT study, there was some kind of comment in regard to how much of the vascular invasion there is. Teach us a little bit about what's a V4, V3, V2.
So really, I think if you just look at top line, you think the REFLECT excluded any patient with portal vein thrombosis, but that was not the case. It was really just major portal vein, which is a VP4.
Okay.
And then as you go into the liver and they branch more and more, it becomes a VP3 and VP2 and VP1. And the smaller ones were all allowed in that trial. It was just a major portal vein thrombus, VP4, that was excluded in the REFLECT trial.
Thanks for reminding us of that. If anything, it's very important to remember that this is not a absolute criteria. If anything, however, and expectingly, as exactly Farshid is mentioning, patients with really a VP4, they're gonna sadly be sick to begin with, so they might not be eligible for therapy anyway. But with this said, let's go back to Riyadh. You already mentioned, and that's really what triggered the question. You said trying to take care of the whole liver. What other methodology you could have used in that setting beside a chemoembolization?
Yeah, so I think this is a prime case where we can sort of bring up the discussion of radioembolization as an alternate to chemoembolization, because the reality is one of the advantages of radioembolization, which is sort of methodologically very similar. You place a catheter in the artery and you inject something. In this case, you just inject these radioactive beads. The reality is that this therapy has been shown to be much more nimble in terms of what it can do. Not only does it treat the tumor, it gives you a sort of biologic test of time, but it also hypertrophies the contralateral side. So it brings in a narrative of possible resection to patients where you might not have had that discussion up front, such as early Bs and challenging As, for example. And so certainly one thing to consider in a patient like this in the future is if you have unilobar disease, and as we know, cirrhotic patients have small left lobes in general, but you want to hypertrophy them. One of the techniques that we've been using that has replaced portal vein embolization in our experience is radioembolization because of the advantage. So high response rate, you're treating the tumor, and you're hypertrophying the other side. And so now we have a large series of patients like this where, as we mentioned before, individualizing patient care, now all of a sudden you think outside the box, you've got good tumor biology. Okay, well, you're BCLCB, but now maybe you're even resectable. And so it allows you to sort of expand the armamentarium of treating these types of patients, and that's what we've done with radioembolization.
Teach us a little bit more about radioembolization, because in all fairness, some of us don't know much about it. Teach us.
Radioembolization is again technically very similar to chemoembolization, where the catheter is placed inside the liver of the artery feeding the tumor, and because tumors are hypervascular, whatever you're injecting accumulates inside the tumor. In this case, you are injecting micron-size radioactive particles embedded with yttrium with a half-life of about 2.5 days or so. So you have about 14 days of activity, and it functions as a low-dose rate brachytherapy type methodology. But most importantly, Ghassan, it's not an embolization procedure, right? The issue with, say, bland embolization or chemoembolization is that you block the vessel. Blocking the vessel causes pain, ischemia to the liver. That's how you have post-embolization syndrome. With radioembolization, you're just injecting these beads. They don't change the blood flow, and as a result, patients go home the same day. So what you've done now is theoretically gotten something with a high tumor response rate on an outpatient basis without the issue of occluding vessels, which can happen after multiple chemoembolizations. So it really is, sort of, in my opinion, the next generation type of embolotherapy, and when done well, you can get very, very good results with this technique.
I totally agree. That's great to hear. So now, Amit, again, we'll ask you as a hepatologist, and this is definitely a patient who really needs your care. What do you advise our colleagues in, especially oncology, how to manage or how to kind of maximize on the liver function? What does this patient need from the hepatology standpoint?
Yeah, I think that, like we've discussed, I mean, these patients are really best treated in a multidisciplinary setting where the hepatologists are not brought in late into the game after a patient decompensates, but really brought in early and follows the patient through that entire course. This patient started with ascites and lower extremity edema, so should have been on diuretics at that time. And then once again, monitoring that patient through the therapy. And actually at this point, the fact that this patient has been treated and actually has a complete response in terms of tumor, but has worse liver dysfunction, this patient can actually be considered as downstaged and potentially listed for transplant once again, he'll have to, continue having a response and stay within criteria. But this is a disease within a disease, as Riyad brought up before. And so now that he's had a good response to the tumor, it really is taking care of that liver dysfunction. And transplant is a cure.
And so beside the diuretics, if needed for ascites, lower extremity edema, sometimes even, sadly, we see testicular scrotal edema, what else do you give them?
So if, for example, if he has hepatic encephalopathy, he may need lactulose, he may need rifaximin.
Okay.
You're going to have dietary recommendations in terms of maintaining a good protein diet, low salt diet. And then otherwise, he's going to need varices surveillance. So the other thing that these patients can have is portal hypertension. They can have large dilated veins in the esophagus that can be prone to bleeding. And so he'll need to be followed by EGDs as well.
Beta blockers?
Depends. So it depends on, once again, if he has the presence of these varices. And if he has varices present, then you could either band those varices, so treat them mechanically, or you can start them on beta blockers. But we don't routinely start beta blockers outside of the presence of varices.
Okay, well, interesting, because, and I don't know if it's correctly or wrongly, but I do understand that some physicians, being either hepatologist or oncologist, might put the patient on a prophylactic beta blocker. What's the value of that, or what's the data?
Yeah, so outside of them having varices, starting somebody empirically on a beta blocker doesn't actually delay, it doesn't prevent or delay the onset of varices. And so all you do is you get the side effects from a beta blocker, increased fatigue, et cetera, without any of the benefit.
Does it help at all in regard to the ascites?
So you're decreasing portal hypertension. You may have some benefit in ascites, but it's not one of the
But
primary.
not magical.
It's not the primary management of ascites.